The tubing attached to a suction unit must be thick-walled, non-kinking, wide-bored tubing. This is because the tubing must not collapse due to the suction, must allow chunks of suctioned material to pass, and must not kink, which would reduce the suction. The tubing must be long enough to reach comfortably from suction unit to patient. Currently, the most popular type of suction tip is the rigid pharyngeal tip, also called Yankauer, tonsil sucker, or tonsil tip suction. This rigid device allows you to suction the mouth and the pharynx with excellent control over the distal end of the device. It also has a larger bore and pharynx with excellent control. It also has a larger bore than flexible catheters. Most successfully used with an unresponsive patient. Rigid tip suction must be used with caution, especially if the patient is not completely unresponsive or may be regaining consciousness. When the tip is placed into the pharynx, the gag reflex may be activated, producing additional vomiting. It is also possible to stimulate the vagus nerve in the back of the pharynx, which can slow the heart rate. Therefore, be careful not to suction more than a few seconds at a time with a rigid tip and never lose sight of the tip. Suction catheters are flexible plastic tubes. They come in various sizes identified by number. French. The larger the number, the larger the catheter. A 14 French catheter is larger than an 8 French catheter. These catheters are usually not large enough to suction vomitus kink. Flexible catheters are designed to be used in situations when a rigid tip cannot be used. For example, a soft catheter can be passed through a tube such as a nasopharyngeal or endotracheal tube, or used for suctioning the nasopharynx. A bulb suction device may also be used to suction nasal passages. Another important part of a suction device is the collection container. All units should have a non-breakable container to collect the suction materials. These containers must be easily removed for disposal or decontamination. Remember to wear gloves, protective eyewear, and a mask, not only while suctioning, but also while cleaning the equipment. Most modern suction devices have disposable containers to eliminate the time and risks involved in decontamination. Suction units also must have a container of clean, preferably sterile water nearby. This water is used to clear matter that is partially blocking the tube. When this partial blockage of the tube occurs, place the suction tip or catheter in the container of water. This will cause a stream of water to flow through the tip and tubing, usually forcing the clog to dislodge. When the tip or tubing becomes clogged with an item that will not dislodge, replace it with a new tip or tubing. In the event of copious, thick secretions or vomiting, consider removing the rigid tip or catheter and using the larger bore rigid suction tubing. After you are finished, place the standard tip back on for further suctioning. Techniques of suctioning. Although there may be some variations in suction technique, a suggested technique is shown in Scan 9.4, a few rules always apply. The first rule is always use appropriate infection control practices while suctioning. These practices include the use of protective eyewear, mask, and disposable gloves. Proper suctioning requires you to have your fingers around and sometimes inside the patient's mouth. Disposable gloves prevent contact between the EMT and the patient's bodily fluids. Protective eyewear and mask are also recommended since these fluids might splatter or the patient may gag or cough, sending droplets to your face, eyes, and mouth. The second rule is to try limiting suction to no longer than 10 seconds at a time. This is because prolonged suctioning will cause hypoxia and potentially death. If the patient continues to vomit longer than 10 seconds, however, you must still continue to suction. Ventilating foreign matter into the lungs will also cause hypoxia and possible death. In short, suction quickly and efficiently for as short a time as possible. Patients who need airway control and suctioning are often unconscious and may be in cardiac or respiratory arrest. Oxygen delivered to this patient is very important. During suctioning, the ventilations or other methods of oxygen delivery are discontinued to allow for the passage of the suction catheter. To prevent critical delays in oxygen delivery, suction the passage of the suction catheter. To prevent critical delays in oxygen delivery, suction quickly and efficiently until the airway is clear. Then resume ventilations or oxygen delivery. In a few cases, you will pre-oxygenate a patient before suctioning. This means that you will adequately ventilate the patient with supplemental oxygen before suctioning because oxygen levels will drop during suctioning. For example, during routine suctioning of an endotracheal tube. If you come on a patient with vomitus or other materials in his airway, or if a patient vomits suddenly and unexpectedly, you should suction immediately without pre-oxygenation. In these cases, pre-oxygenation would force foreign substances into the lungs, which can be fatal. I'm going to go back to 209, and we're going to look at scan 9.4. Suctioning techniques. If you are using a flexible catheter, measure it from the patient's earlobe to the corner of the mouth, or from the center of the mouth to the angle of the jaw. 1. Turn the unit on, attach a catheter, and test for suction at the beginning of your shift. 2. Position yourself at the patient's head and turn the patient's head or entire body to the side. 3. Open and clear the patient's mouth. 4. Place the convex side of the rigid tip against the roof of the mouth. Insert just to the base of the tongue. Apply suction only after the rigid tip is in place. Do not lose sight of the tip while suctioning. Suction while withdrawing the tip. If you are using a flexible catheter, measure it from the patient's earlobe to the corner of the mouth, or from the center of the mouth to the angle of the jaw.